So good afternoon, everybody. Today we'll start with anticoagulants. Okay. So yesterday we had a brief overview about what is hemostasis, right? So I'll just give an outline. So basically, when there is vascular injury, so three things happen simultaneously. So first is vasoconstriction, so that the blood flow is decreased. Second is platelet plug formation, followed by this fibrin mesh formation. So it is like first vasoconstriction happens. So above that, all the platelet aggregation. So you'll have different steps in platelet plug formation. So all your platelets will come and aggregate on that. So above that, this fibrin mesh will come and cover. So imagine you have a injury. So first there is vasoconstriction to stop the blood flow. Then all the platelet plug is being formed, and above that this fibrin mesh has been comes and attaches. So there's a clot formation, okay. And later on, this is followed by, in order to maintain the normal balance, this is followed by fibrinolysis. That is, there is lysis of this, and there is normal hemostasis. So that is basically the overall coagulation, the overall hemostasis ka thing. So now we'll look into individual thing. So first is coagulation cascade, as we know. So first was what I told you is there is vasoconstriction, right? So that is called as extrinsic pathway, and this platelet plug formation is responsible for this intrinsic pathway, okay? So when there is vasoconstriction, so all these three steps, that is the vasoconstriction, platelet plug formation, and this coagulation cascade happens simultaneously, okay? So when there is vasoconstriction, this is known to activate, this is known to activate the extrinsic pathway, this is known to activate this tissue factor, okay? And when there is platelet plug formation, this is known to activate this intrinsic pathway, okay? So simultaneously. So what happens is, intrinsic pathway secondary to activation of platelets, it is known to activate the conversion of factor 12 to 12A. This A is the activated form, 12 to 12A. So this in turn helps in the conversion of 11 to 11A, which in turn helps in the conversion of 9 to 9A. And simultaneously this side also this conversion is happening. That is the tissue factor which has been released from this vascular injury, that is vasoconstriction. It is known to cause, that is the factor 3, it is known to cause the activation of factor 7 to 7A, okay. So up to here there is two different pathways, that is intrinsic pathway and extrinsic pathway. So this in turn connects to this common pathway, that is from factor 10A, it is called as common pathway, okay. It is a common pathway. So this common pathway, that is 10 gets converted to 10A, that is the common pathway. Then with the help of factor 5A, it helps in the conversion of factor 2 to 2A. That is, factor 2 is prothrombin and 2A is thrombin, okay. And this 2A, that is this thrombin, in turn helps in the conversion of factor 1. Fibrinogen is factor 1, okay. And this is factor 1A. Helps in the conversion of factor 1 to 1A. Understood? And simultaneously, this thrombin also helps in the conversion of factor 13 to 13A. So first, from factor 10A, your thrombin has been formed. This thrombin helps in the conversion of fibrinogen, that is factor 1 to 1A. Your fibrin has been formed, okay. And simultaneously, thrombin is also helping in the conversion of 13 to 13A, and you have 13A, okay. So now at the end, now what you have 1A, that is fibrin, and you have 13A, okay. So these together help in the formation of this fibrin mesh. So this fibrin is just, see, fibrin, we just have the molecules kind of thing, whereas these together helps in the formation of this mesh. So this mesh comes and covers your platelet plug formation. Understood? So this is happening, this is your coagulation cascade in general. So this is one part, and another part is your liver. Your liver is known to produce these clotting factors, okay. That is factor 2, factor 7, factor 9 and factor 10. So this goes in, takes part in this, okay. So this vitamin K, that is the oxidated form of vitamin K, gets converted to the reduced form in the presence of vitamin K epoxide reductase, okay. This in turn helps in the gamma glutamyl helps in activation of this gamma glutamyl transferase, which in turn goes to your liver and helps in the conversion of this to the functional proteins, not the activated forms, to the functional proteins, okay. At the same time, it is also producing protein C and protein S. So what is protein C and protein S? These are antithrombins. So these are the coagulants which is present in your body. So these are the these are the clotting factors, and these are antithrombins. It is known to cause that balance. So you should have that balance between clotting and prevention, right? So this helps, acts as antithrombin, okay. Protein C and protein S, okay. So now once this protein C, that is the antithrombins, protein C and protein S are formed, this is known to inhibit the activated forms later, like when you need the balance, the activated forms of factor 5A and 8A. Okay, so this is the overall thing. So this liver is known to produce these clotting factors, which is known to in the presence of gamma glutamate transferase, this is known to cause functional proteins. Okay, and it also produces protein C and protein S. Okay, so this is about coagulation cascade. Now coming to drugs. So we have different types of drugs. That is, first is we have parenterals and orals. Anticoagulants, we have parenterals and orals. So the drugs is classified based upon the site of action, like which clotting factor it inhibits. Okay, so first coming to parenterals, that is first is heparin. In parenterals we have two types. That is indirect thrombin inhibitor and direct thrombin inhibitor. Okay, so indirect thrombin inhibitor, first is heparin. Heparin is known to inhibit majorly factor 10A and factor 2A, and in addition to that it is also known to inhibit factor in intrinsic pathway, it is known to inhibit factor 11, 9, and in extrinsic it is known to inhibit also factor 7. Okay, heparin less, but then more it is known to inhibit factor 10A and factor 2A. Okay, now I'll go individually. So first heparin. Heparin is known to have heparin. Okay, first is parenterals. That is those three types. That is unfractioned heparin, low molecular weight heparin, and we have fondaparinux. So these are the parenterals. Okay, these are the parenterals which is available. So heparin. Heparin is unfractioned heparin. So unfractioned means the molecular weight is found to be high. So we have 1, 2, 3. Okay, so this is heparin. This is a molecular. This is a molecular structure of heparin. Okay, so heparin is known to have this pentasaccharide unit, and it is known to have this GAG complex. Okay, this GAG is the GAG is glycosamine glycan structure. Okay, that is GAG. Okay, so now this pentasaccharide unit is known to inhibit factor 10A. So this it will go to a coagulation cascade, and this pentasaccharide unit inhibits this factor 10A, whereas this GAG complex is known to go and inhibit factor 2A. Understood? So this is a main mechanism of action. So how does heparin shows its mechanism of action? So once you give the heparin subcutaneously, this will go and bind to your antithrombin 3. This is something which is present within you. So this goes and activates this antithrombin 3, and this complex in turn goes and shows this action. Understood? So heparin is something, one disadvantage of heparin, it is something which requires antithrombin. Only then it will show its action. Whereas the direct thrombin inhibitors doesn't require this antithrombin 3. Okay, so that is the difference. Next, coming to low molecular weight heparin. Later on, this unfractioned heparin was reduced into its low molecular weight. So that is, it had a pentasaccharide unit with less GAG complex. This was a longer complex, right? So this had a shorter complex. So that is why this is known to have, so as I told, pentasaccharide unit is known to inhibit factor 10A, and GAG is known to inhibit factor 2A, right? But then since this is long and this is short, it is known to have high activity towards factor 10A. Okay, next coming to fondaparinux. So what happened in fondaparinux? They just only kept the pentasaccharide unit. It doesn't have that GAG complex. So that is why it is direct 10A inhibitor. Again, all these three require antithrombin 3. Antithrombin 3 will bind to this antithrombin 3, it will form the complex, and only then it will inhibit these factors. Okay, so that is a difference. That is why it is called as indirect thrombin inhibitors. Okay, next we have direct thrombin inhibitors, that is argatroban, lepirudin, and bivalirudin. So what they do is they'll directly go and inhibit your 2A. That is the direct thrombin inhibitor. So that is about parenterals. Next, coming to oral. The oral forms, we have again three types. One is vitamin K epoxide reductase inhibitor, that is your warfarin. Then we have direct 10A inhibitors, and then we have direct 2A inhibitors. Okay, so vitamin K epoxide reductase, that is warfarin. Then 10A inhibitors, it is apixaban, rivaroxaban, and edoxaban. Okay, and direct 2A, we just have only one oral agent, that is dabigatran. Okay, so I'll tell you an easy method. See, this direct 10A, apixaban, see it's having 10A, rivaroxaban, edoxaban, so direct 10A. Whereas, what is 2A? It is thrombin, right? So argatroban, thrombin. Okay, you can remember like that. Same thing here, yeah. So these are the oral agents, okay? So now what does this, okay, so VKOR is inhibitors, it is warfarin, okay, the drug is warfarin. Okay, so vitamin K epoxide reductase. So what it does is it will come and inhibit this enzyme. So because this enzyme has been, this vitamin K epoxide reductase enzyme has been inhibited, this in turn prevents the formation of this functional clotting factors. That is why it will help in it will prevent the formation of the functional clotting factors. Okay, so always have you seen whenever you give warfarin, the patient is always put on heparin. Have you heard something called as bridging effect? Yeah, so so whenever you put a patient on warfarin, you will have to give the patient, you will have to put the patient on heparin as well. That is, you will have to put the patient on heparin for 5 days. Only then the patient will be taking warfarin, at the same time the patient will be put on heparin. Okay, and you can stop heparin after 5 days. The reason is this, because once you give warfarin, what is warfarin known to cause? It will inhibit all this, right? So when you inhibit this, even protein C is getting inhibited. As I told you, protein C is required to prevent the formation, prevent this action, right? 5A and 8A. So when you give heparin, this has been reduced. This protein C has been reduced. So this has been predominant in your body, right? So when this is predominant, this can result in thrombosis. So again, it is like, even though you're giving heparin, you are increasing the thrombus formation, right? So in order to inhibit this thrombus, you're putting the patient on heparin. So that is called as bridging effect. So this will take almost like 4 to 5 days. So that is why 5 days you should give heparin, and once these thrombin has been inhibited, you can give the warfarin takes its action, and that time you can discontinue heparin. Okay, so this is called as bridging effect. So that is about vitamin K epoxide reductase. Next we have direct NA inhibitors, that is apixaban, rivaroxaban and edoxaban. So what they do is they'll directly go and inhibit this 10A. So that is that. Next class is direct 2A inhibitors, that is dabigatran. So that will directly go and inhibit this 2A, that is your thrombin. Okay, so that is about oral. Now parenterals, what are these? I told you these are indirect thrombin inhibitors. So we have something called as direct thrombin inhibitors. Okay, so that is of 3 types. Direct thrombin inhibitors, okay, parenterals. That is of 3 types. That is, first is argatroban. Next we have lepirudin and bivalirudin. Okay. So just like I told, direct thrombin inhibitor. So you can remember thrombin. Okay, argatroban, lepirudin and bivalirudin. Okay. So again, the difference between this and this is, these are indirect and these are direct, right? This doesn't require AT3. It will directly go and inhibit your 2A factor. Okay, that is why it is called as direct thrombin inhibitors. Okay, so we'll revise the classification of anticoagulants. So coagulants are divided into 2 types, that is parenterals and orals. So parenterals are further into 2 types, that is indirect thrombin inhibitor and direct thrombin inhibitor. So indirect thrombin inhibitors are of 3 types: unfractioned heparin, low molecular weight heparin and fondaparinux, whereas direct thrombin inhibitors are of 3 types: argatroban, lepirudin, bivalirudin. Okay. Now coming to oral anticoagulants, we have 3 classification, that is vitamin K epoxide reductase inhibitors, that is this VKOR epoxide reductase inhibitors, then direct 10A inhibitors, direct 2A inhibitors. So under vitamin K epoxide reductase we have warfarin. Under direct NA inhibitors we have apixaban, rivaroxaban, edoxaban, and under direct 2A inhibitors we just have one, that is dabigatran. Okay. So that's it about anticoagulants.